Thank you. It's a pleasure to be back with AIDSImpact. Greetings from Geneva. Good afternoon, good morning, good evening, everyone. The HIV epidemic has changed the path of global health. It has promoted science-empowered communities, promoted global solidarity. However, the world has changed, and I do think it is appropriate and timely to ask ourselves whether COVID will change global policy regarding HIV. That was the title that was given to me. Or more broadly, how will COVID affect global health and global policies regarding health? I'd like to start with a few background observations on COVID-19 and HIV before addressing those questions. In the last 14 months, there's been 136 million cases of COVID-19 recorded, probably an underestimate, and close to 3 million deaths. The patterns of the disease, as you would know, are now clearly characterized. I've put some of these on this slide, and what I emphasized in red are a few issues or thoughts that sort of echo HIV and what we heard or witnessed in HIV. So COVID-19 is a global pandemic that continues to expand, just as HIV/AIDS does. It's due to a highly transmissible respiratory virus, SARS-CoV-2, with now phenotypic variants being detected across the world. Most importantly, the infection can be asymptomatic or present as a mild or severe disease. And the fact that the virus is infections before symptoms appear, which is also a feature of HIV, of course, has contributed to its spread to nearly every country across the globe, just as for HIV. Transmission can be slowed down by a package of measures, including early case detection, contact tracing and isolation, physical distancing, limits on travel and gathering, hand hygiene, and mask wearing. Importantly, and again in echo to HIV, these measures require actions by individuals, communities, and local and national governments. And finally, we now have access to effective vaccines, but that access is highly unequal, just as access to ARV has been unequal for a long time. More lessons on COVID-19. Clearly, the world was not prepared. The already known existential risks posed by pandemic threat had not been taken seriously by the world. Whereas the virus can affect all, it does not affect people equally. Again, something that echoes very much HIV. Inequalities both within and between countries have worsened, as vulnerable and marginalized people in a number of countries have been left without access to healthcare, not only to treat COVID-19 infection, but also because health systems have been overwhelmed, shutting many out of basic care and services. And lastly, the socioeconomic impact of the disease and of its countermeasures, including lockdowns, is of unprecedented magnitude. A little more information or background to that impact, just as in the case of HIV, the poorest are obviously the least able to cope with the impacts of the pandemic, Women are disproportionately impacted. They're likely to engage in unpaid care work, for example, due to school closures and to care for the sick. Workers in the informal sector have little savings and have little to no access to social protection. Millions of migrants have lost their jobs and income already, reducing their contribution back home. That is, the dependence of countries on remittances from abroad is highly affected. And something we didn't really know in the early days of HIV is that there is a digital divide that is exacerbating inequality because between those who have and those who have not access to digital technologies. This slide shows the unprecedented impact on development, the socioeconomic impact of COVID-19. As you can see in this brown bar to the right, quite drastic change in the Human Development Index as compared to the small reduction that we saw in the time of the global finance crisis in 2008, 2009. And to illustrate the indirect impact of COVID-19 on HIV, TB, malaria, let's just look at HIV. That is the upper graph and upper circle to the right. As you can see, basically all countries in the world have reported disruptions in access to HIV services, and over 50% had moderate disruptions, and more than 30% had high or very high disruptions in access to services. HIV, and this is the latest slide I could put together. It's still 2019 cumulated data. All of these numbers will be familiar to most of you. 38 million people living with HIV, 1.7 million new infections recorded in 2019, and 700,000 deaths. Progress on the cascade, particularly on the first 90, which is here 79%, but the latest information from UNAIDS is closer to 85. But still overall, only 2 out of 3 people living with HIV accessing antiretroviral treatment. And the main feature of HIV/AIDS today across the world is that some people are at much higher risk of acquiring HIV than others, and that is young women in sub-Saharan Africa, and then people who belong to what we call key populations, again, well familiar to all of you. The point is that the inequalities that facilitated the spread of HIV/AIDS are getting worse, and they continue to promote the spread of HIV in many parts of the world. So addressing those inequalities is at the very basis of the strategies we have or should have now to fight HIV/AIDS. So putting that information together, as it actually is nicely spelled out in the last strategy from UNAIDS, I think what we have learned from HIV and need to think hard when we address COVID-19 is both the success of the HIV movement in building community resilience and global solidarity. Clearly, it is critical whenever you address any pandemic to build on knowledge and tools gained in fighting earlier epidemic outbreaks And this has not been the case in COVID-19, except for a number of countries in Asia, those who experienced MERS or SARS and who were really containing the disease or capable of containing the disease from the very beginning. For most countries in the world, it is now about trying to control transmission. And here, as in any other disease, communicable disease, and as in HIV, human behavior plays a vital role. And among the lessons that we should have learned, but haven't enough from HIV, community building works much better than edicts from above at a time when governments are really ruling global health rather than building resilience from communities. At a time when vaccines are presented just as a magic bullet, it's good to remember that in HIV, we learn to think harm reduction more than risk elimination. And so, as said in the UNAIDS strategy that I already referred to, the resilience and experience of the HIV response in addressing inequalities that affect the key populations is critical to build back better from COVID-19. That about resilience. And then another key lesson from HIV is that as for HIV/AIDS, the unprecedented magnitude of the COVID crisis now requires a global solidarity effort at an unprecedented scale. That HIV led to outstanding global solidarity and shared responsibility was recognized in the last political declaration at the United Nations special session on of the General Assembly on AIDS in June 2006. And here is a quote from that political declaration, where member states recognize that the AIDS response has been transformative, demonstrating outstanding global solidarity and shared responsibility, advancing innovative cross-sectoral and people-centered approaches to global health, and fostering unprecedented levels of comprehensive research and development. I don't think, looking back at the last 12 months, that any of those lessons were seriously taken when it comes to COVID-19. And we better do and think about it, because a number of signals point out now to the fact that for COVID-19, just as for HIV, we will move from an acute pandemic to a sort of endemicity state. We should certainly not assume that the recent scientific progress on COVID-19, be it around diagnostics, rapid tests, or vaccines, of course, will end the pandemic. The world is likely to have many more years of COVID-19 and COVID-19 decision-making ahead. So a nationalistic rather than a global approach is not only morally wrong at this time, but it will actually delay any return to a level of normality that we seek, because no country can be safe until all countries are safe. And we should also note that when it comes to HIV, the world was far too quick to lose interest once HIV was removed as a significant public health threat in the richest countries. Now, as I said in the beginning, 2020 is a very different context for global health from the context that the HIV virus found at the end of the 90s and early 2000s, at the time when the HIV movement was building up. The world has accelerated in terms of globalization. We've seen new patterns of inequities emerge, particularly more inequities within countries than in between countries. We've seen new economic powers emerging and geopolitics that have radically changed. We're not anymore in the 2000 world where there was a global north and a global south. We're actually in a world of multipolar geopolitics. We're also in a world where health is much more of a commercial issue than it was, and a world of paradox where we have never been as connected to each other as we used to through, of course, the internet, social networks, and so on. And yet, as much as we are connected, it seems that we're moving, all of us, more and more to looking inwards and individualism. It's a world where there's less political mobilization around global health and global solidarity than in the 2000s, less international debate around global public goods, where official development assistance for health has stalled, when there is uneven commitment to multilateralism, and basically a lack of progress or significant progress of a framework for intellectual property rights since 2001. It's also a world where, as I said, there's no more global north and global south, and many people are actually talking about the need to decolonize global health. And here is a quote from Uzma Khan in a recent post in Health Policy Watch. And she says, from the pre-colonial to the post-colonial era, we continue to struggle for equitable partnerships with funders and global policymakers to truly make an impact. This results in an ongoing divide between the North and South, where the South struggles to find a seat at the table to raise local voices for a global change. And of course, we are now in the era of the Sustainable Development Goals that are about global health and not anymore in the era about the Millennium Development Goals that were more about how would North-South solidarity help development of the global South. We're also in times where politics are more and more into global health. The global health agendas are increasingly polarized, increasingly politicized. If you think of the Trump administration or what's happening in Brazil or in some Eastern European countries, there's clearly a clash between norms and ideology. There is a lot of misinformation, mistrust. There is a rise of nationalism in the face of an interdependent world. There's use of health, for example, COVID vaccines, as a political tool. And of course, beyond the impact on public health, the pandemic has significantly exacerbated democratic regression in a number of countries. The best illustration of all of these challenges is in COVID vaccine nationalism. Currently, as I speak, I don't think wealthy countries have still fully accepted what enormous global impact the pandemic will have on health, economic, social, and geopolitical issues. Vaccines to governments in the rich North have become the symbol for getting our life back, and our leaders have felt pressured to engage in vaccine nationalism and to promise near full vaccination of their populations. And at the same time, 130 countries in the world have yet to administer a single dose of vaccine. And this is a map taken from a recent publication of The Economist that shows that widespread vaccination coverage will be achieved in a number of countries in dark green by late 2021, for others mid-2022, but from others only from early 2023. So if you think about where we are, there is this paradox between inward-looking nationalism and the fact that the need for international cooperation has never been clearer than today. The need to share information, to ensure access to diagnostics, to vaccines, to protect livelihoods. But it looks like we keep failing as we face one pandemic after the other. And this is not just a health or a sanitary issue. In fact, health has traditionally been a low priority. What is considered high on the political agenda is economy and security. And I think COVID-19 maybe will have, because of its socioeconomic impact and because of its spread all equally to the rich and the poor world, is forcing us to see that without health, society cannot be safe and cannot function. And I believe there is an opportunity now to rethink global health, because global health is now so high on the security agenda driven by the COVID crisis, because health is so high on the foreign policy agenda, which prioritizes, of course, national interests, is high on the economic agenda, continues to be a major contributor to the development agenda, but fortunately remains high on the social justice agenda, which advocates for health as a social value and human rights. And health is recognized as an integral part of the interdependent global crisis challenges, including water, sanitation, and climate change. So will COVID change global health policy? And that was the question that was put to me. As I said in the very beginning, the global response to HIV has changed the direction of global health. It has inspired global solidarity. It has accelerated scientific advances. It has catalyzed community-led interventions never seen before. But in the new and divided world of today, we now have to reimagine global health institution. We have to reimagine global health governance because of the failures of these institutions and of the current governance architecture to detect and to early respond in an effective way to a new pandemic. So we need to reimagine in the world of today that I tried to briefly depict in its strengths and weaknesses, to have a similarly transformative impact on global health as HIV had in the 2000s. We need to radically change the way we think about pandemic preparedness and health security. And looking at the scandal of vaccine inequities, we clearly need to take the opportunity of the COVID crisis to design a new system for innovation, R&D, and equitable access to diagnostic, therapeutics, and vaccines, at least for pandemics. And we should also see the response to COVID-19 as a catalyst to finish the unfinished fight against HIV. So somewhere, despite the struggle that we're in, I believe the COVID crisis provides us with a unique opportunity for new changes in the global health architecture, in global health policies, If we do not take that opportunity now, then when? Thank you for your attention.